Hello, I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care.
Welcome to the Dancing Round the Maypole episode of the Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
So grab your preferred drink of choice, your trainers or your dog lead, and here's what's bubbling up as we dive in search of our pearls for this month. Here's what's bubbling up this week. It's recently been Autism Awareness Day. Over the past 12 months, we've been teaching about autism, ADHD, and the umbrella approach to neurodiversity on our digital and face-to-face courses. You told us that you found this useful and empowering and supporting patients and colleagues, so we thought we'd share our article on supporting a neurodiverse workforce. This might provide tips that we can apply to ourselves, to a trainee or a colleague.
We've also recently had World Parkinson's Day. Parkinson's disease is increasing in prevalence as our population ages. Our role in primary care is to spot it early and refer, and then alongside our secondary care colleagues to support people living with the condition with potentially complex symptoms and drug regimes. So keep listening as we demystify this topic.
And here's what's bubbling under for next week. Lynch syndrome is a genetically inherited predisposition to developing cancer. It's thought to be responsible for up to 4% of colorectal cancer in the UK, often in younger people. It also increases the risk of other cancers, including most commonly endometrial, ovarian, and pancreaticobiliary, but also gastric, small intestine, urinary tract, brain, and skin. In 2024, Bowel Cancer UK told us that it's estimated that there are approximately 175,000 people with Lynch syndrome in the UK, but that only 5% are aware of their diagnosis. Come back next week as we share our article on Lynch syndrome, the role of primary care, how people can access testing, and what support and surveillance can be offered. We'll also cover the role of aspirin chemoprophylaxis.
How can we approach making a diagnosis of pelvic inflammatory disease in general practice? This is important because it has significant sequelae, including subfertility and chronic pelvic pain. However, it isn't easy because it's a clinical diagnosis, it can be asymptomatic, there are no definitive diagnostic criteria, and we can't easily access all the appropriate tests or easily give first-line treatment. So we thought we would share our pearl and discuss our video bite to help find a path through.
So back to the beginning of the bubbles and our first pearl of the month, supporting a neurodiverse workforce. In recent years, there's been a major shift in the recognition and awareness of neurodiversity. Conditions such as attention deficit hyperactivity disorder, or ADHD, and autism can affect clinicians as much as patients. Our pearl and the associated article on Red Whale Knowledge explores some ways that we can understand and support neurodivergent health professionals within the workplace. There are also some associated articles on Red Whale Knowledge that you might wish to refer to, and these are neurodivergence, an umbrella approach, attention deficit hyperactivity disorder, ADHD, autism, and Tourette syndrome and tics. Now, this one took me 24 minutes and 6 seconds to read, so that's quite a long read. It would be a good time frame for maybe a foot spa. Have you got one of those? I keep seeing adverts for them around Christmas time. They always look like a good idea, but I suspect it would just end up being stacked in the wardrobe. So, Ali, what did this one mean for you?
Oh, I'm excited that we're doing this pearl. Neurodiversity is a big passion of mine, something I've been involved with at Red Whale for a while, and I'm proud of all of our neurodiversity content actually. So yes, when we think about supporting neurodivergent people in the workplace, what I would say is useful to keep in mind as we approach this is it's estimated that at least 20% of people have some form of neurodivergence. So actually, unless you work in a super tiny practice, statistically speaking, you almost definitely have neurodivergent colleagues. So this, this really applies to all of us and is useful for all of us. And actually, it is kind to support our neurodivergent colleagues, and we should do that just because that's a nice thing to do. But actually, it makes good business sense, because if you create a working environment in which people with different strengths and challenges are supported to thrive, you'll get better productivity, and your business or your practice will benefit from that diversity of thought and skill that neurodivergent people bring, and that's an evidence-backed claim. So, there's benefits not just to individuals, but also to organisations and to wider society in getting this stuff right. And so I kind of wanted to ask you, Nick, because I'm not a partner or a trainer, but I know you are, whether, that what your experience is around that stuff, and whether, what I was saying kind of reflects your experience in those roles.
Absolutely. And I don't train anymore, but I used to be a trainer. And I know that often just starting that conversation could be really stressful for trainees. And so it's lovely to be able to have an environment where people feel safe to be able to share their concerns, and then to be able to make adaptations to help them to thrive as well. And that's a lovely thing to see when you can do that. And also it's a basic thing, isn't it, that nobody should feel othered, and that everybody should be lifted up. And so it's lovely that we're doing something about that.
Yeah.
So how might neurodiversity affect individual clinicians within primary care? Well, let's take a look at 2 examples. So here's the first one, and it's kind of going back to what we were just talking about. You're the GP educational supervisor to Asif, a GP registrar who will shortly be returning to the practice for a 1-year training post. Asif sends you an email a few weeks before starting the placement saying that he's recently undergone an assessment and was found to be autistic. He would like to meet with you before he begins work in the practice to discuss what reasonable adjustments can be made to accommodate his needs. So how would you approach this meeting? What might help Asif to feel supported and enable him to engage with his training as fully as possible? So that's your first one. Bear that one in mind. And then here's the second one. You are the senior partner of a large GP practice. Layla, one of the nurse practitioners, comes to see you. She bursts into tears and tells you that she's feeling stressed, anxious, and on the point of burnout. She finds it really hard to keep to time or to manage her routine administrative tasks. Alongside the stresses of the job, Layla has recently started to wonder if ADHD might be part of the problem. She's completed an online ADHD screening tool and scored highly. She's asked her own GP for a referral, but the waiting time for assessment in your area is well over a year. So what could you do that might support Layla in the meantime? What adjustments might help Layla to function more effectively in her role and reduce her risk of emotional distress or burnout? As we go through the Pearl, we hope you find some helpful ways to understand and support neurodivergent colleagues. So have those 2 example scenarios in your mind as we discuss things further. So, Ali, what is neurodiversity?
So the term neurodiversity refers to the many different ways that a person's brain might process information. And the term acknowledges that there is a wide range of normal variation in how we do this, and that there is no single or right way to experience and interact with the world. And as we were saying, as many as 20% of the population are estimated to be neurodivergent, and this is unrelated to other demographics like race, gender, or social class. And we got those statistics from the RCGP's journal Innovate in 2023. So from the perspective of neurodiversity, we can view neurodevelopmental conditions such as autism and ADHD, but also dyslexia, dyspraxia, or also known as developmental coordination disorder, Tourette syndrome, dyscalculia, and dysgraphia. All of those conditions, we can view them as differences rather than deficits. And actually those forms of neurodivergence often co-occur, and many symptoms between them overlap. And these differences that people have, they might pose challenges, or they might create areas of need that affect many areas of working life, particularly when people are attempting to fit into a workplace that's set up largely for neurotypical people. But also they can include many areas of strengths and areas of capability. So the sort of different domains of capability that we might be thinking about include things like speaking, listening, understanding, literacy, physical coordination, numeracy, regulating feelings and emotions, vision, auditory processing and other sensory processing, and also memory, attention, organisational skills and time management. And across those domains, everyone will experience a unique pattern of personal characteristics, and that unique pattern can influence how we respond in different situations and how we function at work. And the thing that's key to understand about neurodivergent people is that many neurodivergent people will often have a particularly spiky profile, meaning they perform highly in some areas, maybe, particularly skilled in some areas, but markedly lower in others. And they might have hidden impairments as well. And that disparity, that spikiness of strengths and weaknesses tends to be less pronounced in neurotypical people. And then factors in the external environment can also have a major influence in how these characteristics affect how a health professional functions in the workplace. And we're referencing there the British Medical Bulletin in 2020. So, Nick, what about undiagnosed or unrecognised neurodivergence?
Well, the precise number of neurodivergent health professionals is currently unknown. As high achievers who are often expert at masking, many clinicians may not realise that they are neurodivergent until later life, perhaps when demands at home or work exceed their ability to compensate for differences. Women are particularly likely to be overlooked or misdiagnosed if they don't display disruptive behaviours in childhood, and that's from the Canadian Medical Association Journal from 2022. Individuals from ethnic minority backgrounds may also be less likely to receive a formal diagnosis of neurodivergence, and that's from the journal Autism Research in 2020. Even when recognised, a fear of stigma may make it difficult for neurodivergent clinicians to seek support. An editorial in the BJGP in 2021 describes how many neurodivergent doctors remain undiagnosed and undercover for fear of disbelief or workplace discrimination. And that can contribute to emotional distress and poor mental health outcomes. So, Ali, I've just mentioned masking. Can you just clarify to me what that is, please?
Yes, I certainly can. So, masking is a strategy used by some neurodivergent people, either consciously or unconsciously, to essentially appear neurotypical in order to blend in and be more accepted in society. So, masking could take many forms, but some examples might include things like using facial expressions or eye contact or tone of voice that wouldn't normally come naturally to the person, perhaps by mirroring the behaviours of others. It might also involve suppressing something called stimming, which are often soothing physical behaviours, repetitive things like hand flapping, so suppressing those. Reducing or hiding visible reactions to sensory sensitivities, so, not wincing when a bright light comes on, something like that. Or maybe planning a detailed script in advance of what you want to say to someone.
All of that sounds exhausting.
Yes, so it really takes a toll on people. And in fact, neurodivergent people can spend a lot of time and energy compensating for their differences so that they can succeed in those settings that favour neurotypical behaviours, which is almost all settings. And this masking behaviour is aimed at avoiding negative reactions and rejection and stigma. But as we said, it can be exhausting and it can generate a lot of anxiety and really take a toll on people over time. So we know that masking is associated with negative impacts on mental health, including anxiety, depression, burnout, and increased suicidality. But in contrast to that, developing increased self-knowledge and awareness of underlying neurodivergence can ease feelings of anxiety or low mood and create a sense of empowerment. And a significant improvement in mental health can also happen when reasonable workplace adjustments that suit the person's needs are put in place. So we're going to move on now to think about neurodiversity and the law. And many neurodivergent conditions are considered a disability in the UK as defined by the Equality Act 2010. So the GMC define a disability as an impairment that has a substantial and long-term adverse effect on a person's ability to carry out normal day-to-day activities. And the GMC refers specifically to autism, ADHD, and learning differences, including dyslexia and dyspraxia, in the GMC's welcomed and valued guidance. So employers have a legal duty to make reasonable adjustments to the way they operate in order to support a person to do their job by removing significant barriers that place them at a disadvantage because of their disability. So some examples of reasonable adjustments that might support neurodivergent health professionals to work effectively are summarised in a table that's in the written Pearl, which is based on the article from the British Medical Bulletin in 2020 that I mentioned earlier. And there is also a link to it in the show notes.
Now, rather than just read out the table, which doesn't make hugely engaging podcast content, I wonder if we could revisit those examples from the beginning, Ali, and if you could take us through the scenarios using that table and also the section in the written Pearl, which is called Tips for Creating a Neuro-Inclusive Workplace. So if we start with Asif, and Asif, if you remember, was our GP trainee who has recently been diagnosed as being autistic.
Yes, so thinking about how the table of reasonable adjustments can help us here and how we can approach supporting Asif. The first thing to say is that everyone's needs are unique. So there's suggestions in the table, but actually Asif might have ideas himself about what can help him, and that's where we should start. And really there are limitless possibilities as to what a reasonable adjustment could be. But actually, if Asif thinks, yeah, it might be helpful for you to offer me some things, and he wants us to show him a bit of a menu of things that might help support him, then we might be looking at things like helping improve predictability and routine. So maybe Asif would prefer to always work in the same room rather than be moved between rooms. Maybe there are sensory adjustments we can make for Asif. Maybe he prefers to work where possible in noise-cancelling headphones. Maybe there are changes to his working schedule that would help. So some autistic people prefer working from home where possible to reduce social and sensory overwhelm that comes from coming into the workplace. Maybe you could adjust his clinic times to mean that he's not travelling during the commute, again, to avoid overwhelm associated with that. And another big area is communication. So making sure that we're very clear and direct in communication with an autistic colleague is usually very helpful. And actually, to look at this in more detail, there's a really helpful acronym called SPACE in the written Pearl, which a good take action point might be to look at this part of the article in some more detail, but to just give you a little overview. So S stands for sensory. So that's the sort of things we talked about, bright lights, flickering screens. And if we can adjust those by changing the environment, that can be really useful. Predictability is P, and that's changes around routine and predictability, working hours, regular rooms, etc. A stands for acceptance. So here we're thinking about encouraging a holistic approach which understands and accepts autistic traits and doesn't stigmatise them. So that might involve speaking to the wider team and promoting acceptance, combating stereotypes, using the right language around autism. C in SPACE stands for communication. So that's understanding that autistic people can typically communicate differently from neurotypical people, and sometimes verbal communication can be difficult for them. So again, it's about adjusting our communication style to the individual, as we said, direct language, avoiding idioms where possible, things like raining cats and dogs that make no literal sense. That kind of language can be challenging. And then the E in SPACE stands for empathy. So that's understanding this concept that despite common assumptions and stereotypes, autistic people don't lack empathy at all, but they might experience or express it differently. And even autistic clinicians might experience hyper-empathy, where they feel sometimes overwhelmed and struggle to cope with other people's strong emotions. So that's the SPACE acronym. So do have a good look at that in detail, but that's the kind of framework we would apply to Asif. And then
wonder,
I wanted, go on, Nick. Yeah.
So I was going to say, I just wonder if there are strengths that ASIF will bring, things like the common strengths that would be related or linked to autism.
Yeah, I think that's a really useful thing to think about when we meet ASIF and we think about how we can support him. It's not just about the negatives, it's also about the positives. So the kind of strengths that we see commonly in autism include attention to detail, strong memory and recall, high verbal comprehension ability, honesty, motivation to help others, organisation skills, really deep knowledge in specific areas of interest, can often work very efficiently, have a very strong work ethic, can have very good problem-solving skills and innovative thinking. Autistic people can also have very good observational skills and pattern recognition, and can be good at staying calm under pressure. So loads of strengths.
So haven't you just listed the qualities that we all value in a good clinician?
Well, yes, absolutely. Yeah. And I think that links back to what we were saying at the start of this segment, that, supporting ASIF doesn't just benefit ASIF, although of course that is a value, but it also benefits your organisation, because if he can thrive, then you get access to that huge list of strengths.
Absolutely. Well, thank you for that. And so the second scenario, just to refresh your memory, was Layla, our nurse practitioner, struggling with possible burnout, who was awaiting an ADHD assessment.
Yes. So one key point I wanted to pull out around Layla, which we will go into a bit more detail later, is that, yes, she's not diagnosed yet, but actually she doesn't have to be for reasonable adjustments to be helpful, or for an employer to provide them. So one of the benefits of formal diagnosis is that then those reasonable adjustments become legally binding. But we can support Layla while she's awaiting diagnosis. And then thinking of the sort of suggested adjustments in that table. So one thing to say is the same as we said with ASIF. Everyone has unique support needs, and it would be important to talk to Layla about what's right for her. But typically people with ADHD might find themselves feeling restless, distracted, easily bored, particularly in a role with work tasks that aren't sufficiently stimulating or interesting. So the sorts of things we might talk to Layla about include maybe doing more face-to-face work rather than phone or video work, because some people find it easier to focus in that scenario. Reducing distractions where possible. So Layla might prefer to work in a private room rather than a shared environment. Visual things to help with memory and processing, like using larger screens, dual screens, improving access to movement, so maybe via a standing desk, maybe ensuring regular short movement breaks. And I mean, regular short movement breaks are, of course, great for everyone. A lot of these tips are applicable to neurotypical people as well. Yeah. Another thing that might help Layla is accessing, if possible, sort of ADHD specific executive function coaching or training. And then just thinking about Layla's role and making sure that she has access to new challenges and isn't in a role that's too routine or too boring or too easy for her.
Yeah, absolutely. And again, let's not forget about Layla's potential strengths. So what would they be?
Yes. So I'll list them and again, see what you think, Nick. So people with ADHD can be more comfortable taking calculated risks. They can be more comfortable living with uncertainty. Again, we can see lots of creative thinking and problem solving. They can be strong in terms of the ability to multitask. They can respond well to changing environments and changing work demands. And again, they can be really good at staying calm and composed in high pressure situations.
Which again sounds like super useful traits to have in primary care.
Yeah, absolutely. I think so.
So it's important to say that many individuals will not disclose or even realise that they are neurodivergent. Employers and workplaces should therefore take proactive steps to improve how we support and manage our teams across the board, not simply when neurodivergence has been highlighted as a potential issue. Now, Ali touched on some of these things when she was discussing the two scenarios. Now, the Chartered Institute of Personnel and Development, the CIPD Guide to Neuro-Inclusion at Work, work was developed to help employers create more inclusive workspaces where a diverse range of individuals are able to thrive and experience a sense of belonging. It identifies 7 key principles for creating a neuro-inclusive organisation. And just to clarify, they are: understanding where you are now and commit to a long-term plan of action. So you need to ensure that you act on this plan and demonstrate a lasting commitment to progress towards neuro-inclusion.
And the next step is to create an open and supportive culture where people feel comfortable talking about neurodiversity.
And then next we have proactively consider neurodiversity in how you manage your team on a daily basis. So people should feel included, that they are treated with respect, and that their contribution is valued. It may also be important to review policies and processes such as recruitment, training and staff development to ensure that they are neuro-inclusive.
And the next one is that we should be guided by individuals about what they need to perform their best at work. There should be open and effective conversations about ways to improve support, communicate effectively, and make adjustments or increase flexibility within job roles that may help meet a person's needs.
And then the next one is to embrace flexible working to enable everybody to thrive, because flexible working has been found to have a positive impact on employee engagement, well-being and performance.
And then this is an important one: practice ongoing attention to well-being. So managers should take time to regularly check in with their team and with individual people, giving people the opportunity to raise concerns and ask for support if needed.
And then finally, we have empower neurodivergent voices. Your own team is often best placed to inform you how your organisation may be more neuro-inclusive. Invite participation, but don't expect it. Seek to improve opportunities for two-way communication and feedback, and don't assume that existing channels will be or feel accessible to everyone.
So that's just a flavour of the Pearl. There's a lot more detail about how neurodivergence can affect people at work and how we can support them in the full article. And there's also our separate full articles on ADHD and autism and other forms of neurodivergence if you want to dig deeper.
Yes, and at the end of the Pearl, there is a list of neurodiversity resources. Now, amongst them are a couple of BBC TV programmes, and one of those is Inside Our Autistic Minds with Chris Packham, and it's excellent. I can thoroughly recommend watching it.
Yes, I'm a big fan of that show too. And actually, a little while back, I went on your other podcast, didn't I, Nick?
You did?
Boggled Docs to discuss it. I can't say Boggled Docs. Boggled Docs.
There you go.
And yeah, on the back of that, we were actually contacted by Flo, who featured in Inside Our Autistic Minds, which was great. And she then became actively involved in looking at and developing our content at Red Whale, and she features in our video bite about autism on Red Whale Knowledge.
Yeah, it was so lovely for her to contact us. And if you want to watch that documentary, then I'll put a link in the show notes along with a link to the relevant episode of Boggle Docs, so you can have some CPD from that. So it all sort of nicely falls into place. So here are your take-home messages for supporting a neurodiverse workforce. As many as 20% of the population are estimated to be neurodivergent, and these figures also apply to clinicians and other staff working in primary care. Neurodivergent conditions often co-occur, and many symptoms can overlap.
These can pose challenges or create areas of need that affect clinicians in many areas of working life, but also include many strengths and areas of capability.
Recognising the impact of neurodiversity and taking proactive steps to improve how we support and manage our teams across the board can help create more neuro-inclusive workplaces that enable every member of the team to thrive. So it's always good to get the first one done. How are you doing, Ali?
I'm doing very good. Thank you, Nick. One thing I did today earlier on, which is quite exciting, is I've been setting up, sort of practicing with my tent and things, getting ready for a camping trip because I'm going away this weekend for a child-free weekend away with my friend. Very exciting.
And have you been camping before?
We did it last year. We did the same trip last year once, and it was my airbed deflated and I was freezing, and it was hence me getting everything out and making sure it works this time.
100%. So where are you going?
Well, I hoped you wouldn't ask me this, Nick, because I feel like all I ever do on this podcast is talk about words that I can't pronounce. And we're going to a lovely little town in Wales, the name of which I can't possibly even attempt to pronounce, but it's very nice.
Lovely. Well, it's a lovely part of the world, so have a fabulous time.
How are you?
I'm okay. Yeah, surviving.
Yeah.
It's funny because I was thinking about, how a couple of episodes ago we were talking about, we were doing food pairings and then we changed it to things like sort of soaks in the bath and stuff like that. And I was having a soak in the bath the other week and I was thinking, oh, this is a nice relaxing bath. And as I was sort of looking up at the ceiling, I could see circling around, there was what basically was a hornet.
Oh,
I was thinking, okay, this isn't so relaxing anymore. And then the hornet dive bombed into the bath. And it might as well have been a great white shark. I jumped out of the water so quickly and literally just water all over the floor. What an absolute, disaster and not very relaxing at all. So that was the end of that. So beware hornets or
What
wasps.
happened to the hornet? Did you
Well, I
drown
did
it, or-
actually. I rescued it. And then I popped out the window when it had dried off a bit. So it was on my towel and it was a little bit stunned. So I just put it out the window and it was okay.
Oh,
So.
very, very impressive of you.
There was no screaming,
Kind to
I
hornets.
promise. It was all fine. Deep breaths. So moving on. Are we ready for our second Pearl of the Month?
Yes, please.
Excellent. So this one is entitled Spotting and Supporting Those with Parkinson's Disease. Now, as Ali said before, it's recently been World Parkinson's Day and the prevalence of Parkinson's disease is rising as the world population ages. However, diagnostic processes and management haven't changed greatly in recent years, and in primary care, our most valuable role may be in recognising the early symptoms, prompt referral for specialist diagnosis, and the management of non-motor symptoms. Now, this one took me 32 minutes and 12 seconds to read, so that would be a proper long soak in the bath with some fruit toast and a cup of tea, perhaps. No wasps, though the fruit toast might attract a wasp, so don't have that.
True.
Though maybe a bit of speed reading in the pearl in the middle so that you don't shrivel up like a prune when you're in the bath. What did this one mean for you, Ellie?
Well, can I just ask, Nick, would you really eat toast in the bath? Because that image really weirds me out, like crumbs in the bath. No, thank you.
Well, there'd be a plate. There'd definitely be a plate, and I'd probably eat that over the side so it wouldn't go in the bath.
Okay.
Okay, is that all right?
Well, that's too much admin for me with a plate.
Too
but
much,
you
yeah.
do you, Nick. That's fine.
Yeah, everyone's going, ooh. Anyway, back to the pearl.
I shouldn't judge. Sorry. Yes. So what does the Parkinson's pearl mean to me? Well, I think, when I think about Parkinson's disease, the main thing I think about is motor symptoms. But actually, a big learning point from me from this pearl is that non-motor symptoms are really important and can cause as much distress as motor symptoms. And actually, unlike the motor stuff, there is often lots we can do in primary care to help them.
Exactly. And the NICE guidance on Parkinson's was updated in 2017, NG71. And the bottom line for us in primary care is that if we think somebody has Parkinson's, then we should refer them promptly to secondary care where a definitive diagnosis can be made. So, Ali, what kind of presentation would make us think of Parkinson's?
Well, Nick, as we know, Parkinson's is a clinical diagnosis, and we should suspect Parkinson's in people presenting with tremor, stiffness, balance problems, gait disorders that aren't related to visual or cerebellar or vestibular or proprioceptive dysfunction. And initially, the symptoms of Parkinson's are usually unilateral, but they can become bilateral as the disease progresses. And in primary care, if we suspect Parkinson's, as you said, Nick, we should refer promptly to secondary care. And we, of course, wouldn't commence treatment for Parkinson's in primary care.
Exactly. But what about anxiety? Would that make you think of Parkinson's?
No, is the short answer to that. I don't think it would, but should it?
Well, it's not part of NICE's presenting symptoms which should trigger a referral, but it certainly is an area of interest. Now, this is because anxiety is known to be one of the possible prodromal symptoms of Parkinson's disease. A retrospective UK-based cohort study looked at adults aged 50 or more years old presenting with new onset anxiety and found a strong association with later diagnosis with Parkinson's disease. Now, that's from the BJGP in 2024. The group with new anxiety had double the risk of Parkinson's disease diagnosis when compared with the non-anxious group, even after adjustment for lifestyle, age, sex, social deprivation, history of head injury, severe mental illness or dementia. Now, the study also identified other symptoms in the group with anxiety that were associated with increased risk of later Parkinson's disease, and these were depression, fatigue, sleep disturbance, cognitive impairment, hypotension, tremor, rigidity, balance problems, and constipation. Now, maybe more of us will think about Parkinson's when seeing a patient who is 50 or more with new onset of anxiety in the future after that study. For now, though, I'm pretty sure that we'd all list a tremor as one of the most common presentations. So, Ali, what else could a tremor be?
Well, yes. So, Nick, many people presenting with Parkinson's disease will have a resting tremor as a feature. And classically, this would occur in the hands. And we probably all remember that description from learning about this in uni days, that it's described as a pill rolling tremor. So it looks a bit like someone continuously rolling a pill between their thumb and their index finger. But just as a reminder of other kinds of tremors, so other causes of tremor might cause a different appearance, like a postural or action tremor. That's the commonest type we see, and we might see that when somebody has an essential tremor or an exaggerated physiological tremor, or a tremor caused by hyperthyroidism, or maybe a drug-induced tremor from something like salbutamol. Or a different category of non-Parkinson's tremor that we might see would be an intention tremor. So that's where the tremor worsens as the person moves towards their target in a directed action. And we see that in cerebellar disorders. And so, Nick, what about the pharmacological management of motor symptoms in Parkinson's?
Well, Ali, initiation or titration of drugs will be secondary care decisions. And if you want to have a good old read of NICE's suggestions for medication, then they're summarised in the article for reference. So if you're having that soak in the bath, then go for your life. But for us in primary care, the salient points from NICE are that anti-Parkinsonian medicines should not be withdrawn abruptly because this runs the risk of acute akinesia or neuroleptic malignant syndrome. Now, risks are increased further if doses are missed or there is poor absorption, for example, gastroenteritis or after abdominal surgery. Now, drug holidays are not recommended because of the risks of acute akinesia or neuroleptic malignant syndrome, both of which are life-threatening conditions. The timing of doses is paramount, and patients living in care homes may need to self-medicate to ensure medication times are adhered to.
So, as I mentioned at the top of this one, it's important to raise awareness that people with Parkinson's often have non-motor symptoms associated with their disease, and these can be more distressing than the motor symptoms. So they include things like mood disturbance, behavioural changes, altered cognition, sleep disorders and daytime hypersomnolence, altered sensation of smell, bladder or bowel disturbance, Parkinson's dementia, hypersalivation, orthostatic hypotension, and unexplained pain. And in primary care, we are well placed to identify and manage these symptoms or refer back to neurology for help with them if needed. So detailed management of these conditions is outlined in the written Pearl and in the associated article on Redwell Knowledge. So a take action point here might be to have a read of those different treatment options for those, because if we went through all of them here and now, this episode would become a bit like the never-ending story.
Yes. So, impulse control disorder now to wrap up with, and these have recently been in the news, and there have been cases reported of patients who've been prescribed the dopamine receptor agonist ropinirole for restless leg syndrome and then have developed gambling and spending addiction. Now, one patient claimed that their GP didn't warn them about the side effects, and after taking legal action against their doctor, they received a large financial settlement. So we should warn patients and their carers about the risk of impulse control disorder, both for people with Parkinson's, but also if we're prescribing dopamine receptor agonists like ropinirole for restless leg syndrome. Now, impulse control disorders are a group of psychiatric conditions characterised by repetitive, reward-based behaviours. Now, there's a lack of ability to resist a certain urge to harm oneself or another. They're related to dopaminergic drug administration and affect 14 to 24% of patients on medication for Parkinson's, so they're not uncommon. And examples would be compulsive shopping, binge eating, hypersexuality, and pathological gambling.
So impulse control disorders can affect anyone on dopaminergic treatment, but they're more likely if the person's on a dopamine agonist, if they have a pre-morbid history of impulsive behaviour, and if they have a history of alcohol consumption or smoking. Impulse control disorders can happen at any age, and men and women are thought to be equally affected, although men are more likely to experience hypersexuality.
Impulse control disorder can be very distressing for patients and carers and can even result in financial difficulties and criminal convictions. People affected will often cover up the symptoms, so carers and medical professionals should be aware of this association and ask about it. When carrying out a medication review, we should ask about symptoms if on dopaminergic treatment, especially a dopamine agonist.
And if we think a patient has developed an impulse control disorder, then we should liaise with neurology. And what they might do is change the person's medication, such as reducing the dose or stopping dopamine agonists, and they might also offer CBT. What we shouldn't do is stop dopaminergic treatment in primary care, because stopping treatment suddenly runs the risk of neuroleptic malignant syndrome. And a useful information leaflet for patients is available on the Parkinson's Disease UK website. Links are in the written pearl, and we'll put a link in the show notes too.
So here are your learning points for spotting and supporting those with Parkinson's. If you suspect it, refer. Management of motor symptoms will be advised by secondary care.
Review for non-motor symptoms and treat and refer for those appropriately. Assess for impulse control disorders and refer if they occur. So, Nick, moving on to our trainee package. It's been really popular, hasn't it?
Yes, so the GP Trainee Essential Support Package, this is exclusively available to GPST MDU members and affiliates. So if you are one of those, then it's free and it's worth £165, and it's designed to build your knowledge and confidence and help you pass your exams. And so what's included in it, I hear you ask? Well, it's really helpful because it's got Redwell Knowledge Access, which has got over 900 written resources to support you during consultations and also with your CPD. And also the top AKT Topics Digital Handbook, which covers areas that trainees struggle with most, and webinars throughout the training year to support you with your exam preparation. So if you click on the link, then you can sign up for that.
And Nick, would you like to know the terms and conditions for the trainee package?
I certainly would.
Okay, so the package is completely free for MDU affiliate and GPST members, but MDU GPST membership itself does carry a charge to sign up. And our GP Trainee Essentials package is a free benefit of affiliate and GPST MDU membership.
Cool, thank you. Okay, we just got time for some primary care superheroes.
So thank you so much to Dr. Elizabeth Sherman, or Liz, at Churchdown Surgery in Gloucestershire, who's written in. She says, "Dear Redwell team, I love the podcast and listen every time a new episode is released on my commute to work. Thank you. I would like to make a primary care superhero nomination, please. I'd like to say a big thanks to Dr. Sharon Druitt, who has recently retired from Churchdown Surgery in Gloucestershire. A GP, partner, trainer, sustainability whiz, and all-round lovely colleague who's made such a difference to so many people over her career with her positivity, energy, and enthusiasm for making things better. Thank you for all your dedication, hard work, and determination. It's been a pleasure to work with you." Oh, wow, that's lovely.
Oh, thanks, Liz, for nominating Sharon. That's wonderful. Thank you so much. And we've got one here. It's 2 nominations. It was from one of our face-to-face courses, a GP update course in London recently. The person nominating didn't give their name or the surgery, but they have nominated Sanjay Trivedi and Cheryl Farley, and they say that they were amazing supervisors to them, and they said they were a difficult trainee. They said they were compassionate and patient. So there you go. Hopefully you know who's nominated you, and thank you for that nomination as well. Now, if you are hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale pod members. And how do you know if you're a member, I hear you ask? Well, if you're listening to us, then you are part of our pod. So welcome. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code Red Whale Pod to get 10% off. And here's the small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and all lowercase, Red Whale Pod.
So if you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we'd really appreciate it. And if you can spare a little more time, then please leave us a nice review. Because of the way algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms to the side, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes, and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want us to see something about the podcast, then please use #RedWhalePod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work so we're there with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.